My name's Mr. Vikram Dhar, and I'm the consultant ENT head, neck and thyroid surgeon here at the One Ashford. My primary interest, and one that I'd like to talk about today, is head and neck cancer. In the past, we associated head and neck cancer very much with patients that smoke a lot or drank excessively. And one of the points I want to get across today is the rise in the type of patients we're getting with particular types of cancer, particularly related around the tongue base and the tonsil. The reason for this change away from patients that just simply smoke and drank is that a virus called the human papilloma virus, which the general populace probably heard more commonly with cervical cancer, is showing itself with tonsil and tongue base cancer. We're pretty much all exposed to human papilloma virus, and there are 100 different subtypes. Two particular kinds, HPV 16 and 18, are the ones most commonly found in oropharyngeal cancer. The sorts of patients that we're seeing with that type of disease are often younger. About 2/3 to 80% of the time, they do present with lymph nodes, that's lumps in the neck, often on one side. Quite often they'll complain of one-sided tonsil or back of the tongue pain. Occasionally they'll have symptoms such as pain in the ear, which is referred pain from the problem in the throat. Occasionally they have slight changes in the voice. Symptoms such as sore throats or feeling of something in the throat are incredibly common, but we can't simply ignore them. The earlier you catch them, the better the prognosis. The good news with this type of cancer is that, broadly speaking, they do 2/3 better than the population that is not HPV positive. Investigations that we would perform in the clinic is something called a fibre optic nasendoscopy. That's a small telescope that we pass through the nose and look into the areas of interest at the tongue base, next to the voice box, at the back of the nose. This gives us invaluable information and will most often tell us if there's a problem or not. We also often ask for investigations outside the clinic setting. Typically they are ultrasound, biopsy of the nodes, via ultrasound guidance, MRI scans of the neck and CTs of the chest if necessary. If we have a high index of suspicion that there is a problem in the throat, we will often ask for you to have a small procedure under a general anaesthetic where we localise the area and biopsy it. In the case of a tonsil, this may be a tonsillectomy. Another type of cancer is a laryngeal cancer. Larynx cancers often present to us with a persistent change in the voice. It's very important to think about the word persistent. If the voice comes and goes, that's far less worrying. We know that still 95% of patients that we see with laryngeal cancer are smokers. So in a smoker with a persistent hoarse voice, I would certainly go and see your GP. The great advantage we have with laryngeal cancer over other cancers is that the larynx is a very sensitive organ. A slight change in your voice because of a small growth will show itself very early in the process. And the vast majority of the times when we see larynx cancer, it's very early, very treatable via radiotherapy or laser resection. Another type of cancer that we do see in the neck are thyroid cancers. Thyroid cancers are fairly rare, and thyroid lumps that are not cancerous are extremely common, particularly in women of a middle age. But the most valuable tool we have is ultrasound-guided needle biopsies. The ultrasound itself will tell us about the architecture of the thyroid and will give us invaluable information about how suspicious the nodule is. But also a needle biopsy takes away cells and allows us to understand whether or not they are worrisome or not. More often than not, these investigations point towards a benign outcome and we can leave things alone, perhaps with a surveillance scan. Fairly rarely, it comes back as frankly malignant, and in that case surgery is what would be advocated. Fairly commonly, the needle biopsy sits to a degree on a fence, and in those cases we often do perform half thyroidectomies to be certain of the diagnosis. So my message would be that if symptoms are persistent, particularly if they're on one side, go to your general practitioner, get it checked out, and if there's any doubt, there are surgeons like myself that can use special techniques to be absolutely certain what's going on, and if there is an issue, we're right here to help you to manage the issue, treat it, and hopefully cure you of any problems you might have.